Good morning. All right, I'm gonna wait for 2 more minutes before I'm gonna start because now we're with 22. So um gonna wait a bit longer so most of you are there. 2 minutes, so yay! Somebody turned on the video. You're the only one at the moment. But good to see you. Ah. All the familiar faces. As I said before, I'm gonna wait 1 more minute and then start off because the number of participants is still going up. All right. Okay, I'm gonna start off today's lecture now. 40 of you are there already, so that's good. Again, I would like to ask you if you are able to turn on the video. That makes it a bit more pleasant for me to see some faces. If it's impossible or whatever, that's also fine. It's not mandatory. I've heard that in some courses they do make it mandatory that if you don't turn on the video that you cannot follow the next lecture and stuff like that. I thought that was funny. But you know, you're all adults, so you don't need to, but it's very much appreciated if you do. So if you do, then thanks for that. Also, same goes as last Monday, that if you want to intervene, if you have a question and speak up, then feel more than free to do so. But if you rather ask questions or make remarks on the chats, that's also fine. I'm going to try to keep check on that as much as possible. But both works for me anyways. So first of all, welcome again. Today we're going to talk about quality of care and what is quality of care. Before that, I want to thank you for the emails I received concerning your topics for your essay. A lot of you made use of the possibility to just send some short bullet points or your ideas, and I was very happily surprised with the creative and good ideas that you all had, and sometimes also very extensive outlines. I think I did most of them on Tuesday, and there are like 3 or 4 remaining that I received yesterday. Well, although I set a deadline for Tuesday at 1, I'm going to answer them today anyways. All right, now I'm going to share my screen with you and we'll start off the lecture. I also hope, by the way, that all of you slept well, because what was going on yesterday in Washington was a bit crazy. So it kept me up a bit longer than I anticipated on. But I just got a push message that the Congress confirmed Joe Biden as a new president. So maybe this potential coup didn't work, but crazy, crazy times. Okay, diverging off the topic a bit. All right, we're going to talk about the quality of care. Now, what are we going to do today? We're going to start. Let me see 1 sec. I'm going to see if I can get the chat on as well. 1 second. I still figuring Zoom out a bit more. Chat. Yeah. And I have that if you have any questions. All right. Oh, well. Yes, here we go. All right. Today we're going to start off with a short introduction and a short history of the quality of care. So how did that concept evolve over time? Because that changed during different decades. It can be a bit tricky to define and be all inclusive to what actually good care means. And then the second question, how to manage this, might be an even more tricky one. After that, we're gonna, oh, why is this stuck? see how usually there are kind of, we're going to build it up today in two opposites that often a way to measure quality is addressed by the use of quantitative frameworks, which are very useful and have a lot of benefits, but also have some pitfalls regarding quality. Quality is inherently a subjective concept, so you can imagine that there can be some friction in combining these two. So questions like, can you actually measure quantitatively what quality is? And also concerning the different perspectives different parties in healthcare and people have on that. Is that a feasible question? And it is a very feasible question, but one that has different answers. Okay, then, we're going to look at an alternative approach and also look a bit more at the literature. The literature that you've got for today will take different perspectives on what quality is and how it should be managed. And as you will see, they also come from different traditions in how they try to unravel what quality is and answer that question. Then in the end, we're going to have some conclusions. And as always, this is the first two sessions will be mostly me talking. And the third one, we're going to talk about the assignment. I'm going to go through some bullet points that kind of came back to me also in the breakout sessions last Monday and by our emails. So those are general remarks that might be useful for you all to discuss a bit. And then we're going to work in breakout rooms again. So that's the plan for today. All right, well, let's start at the core. Quality as a key organizing principle. Definitions that you can find on the World Health Organization website are the following. The first one: health is a state of complete physical and mental social well-being and not merely the absence of a disease or infirmity. Now, I want to give you a minute to think about this definition. And maybe I think it's an interesting definition, let's say. So think about it, how workable and feasible you find this definition. Just the first one, now health. And maybe put some remarks in the chat or speak up if you want. Anybody, some remarks, or still waking up today? Perfect. I got in the chat, you can see the comment of Daphne. And this is what I wanted to discuss as well, what she's saying with this definition. I don't think there are a lot of people who you can consider healthy. Yeah, that's exactly one of the points that I wanted to make, because if you look at how it states complete physical, mental, and social well-being, I don't know about all of you, and I really wish you all to always be in a complete state of physical, mental, and social well-being. But for myself, I could say that not every day I would consider myself to be in this complete state. Because, well, physical is one thing, but even, well, let's say if I'm stressed, I get cold sores, then I don't have a complete physical well-being state. Mental and social well-being also quite hard to determine what that then means. I mean, the last year for everybody, I think, if you look at social well-being, yeah, I have not been on a scale of 10 every day in this situation. So it is, health is very hard to define. So if there is one definition that would be totally clear cut and workable, is the question anyways. But this one is quite optimistic, and there also has been quite a lot of debate and research about it, whether this was the most workable definition to go by. I will come back to that later because there were some other propositions, or other propositions have been made. But this is the one that is still maintained now by, I would say, one of the leading healthcare organizations of the world. Now, second then, quality, which we're going to talk about today, the extent to which healthcare services provided to individuals and patient populations improve desired health outcomes. Now take another minute and maybe put some of your thoughts on the chat, if you may. Any thoughts?
I would say maybe that here it says it's only about the health outcomes, but I also have the feeling the quality about healthcare should also be the means to get these outcomes. Like if I develop a therapy that is very, very painful for patients, but in the end they're healthy, it might be not as good as if I have a therapy that treats the patient not as good in the end, but is pain-free.
Yeah.
So I have the feeling the quality should not only be determined by the health outcomes, but also maybe by the means to get there.
I think that's a very good point that you're making, because this definition excludes the process to come there. And then, first of all, it's excluded. So it is very focused on the outcome that you get. But how did you get there is a more tricky and complex question. And also, again, is there one way to do that? Is it also not personal? I mean, healthcare is about, it's a very bodily and personal thing. It's about your health. So there, I think you make a very good point. Also, I think what I thought of this definition is that you can almost debate whether it is framed enough, or there are enough boundaries for even to be a definition, because to the extent, what does that actually mean? What does that entail? So you already see here with the two key concepts of, well, I think healthcare organizations, because this should be, I may say, the leading motivation to actually provide care, that the core concepts are quite tricky and debatable. All right. Yes, so, but quality, one thing, it is a ambiguous concept as it is, but what it also is, because debatable does not mean, by the way, that it's a good thing that we keep debating about it, because this keeps us sharp and improving the process of how to provide these services. But one thing that quality does, it is a shared objective. It is very hard to disagree that quality is not a thing to aim for in healthcare. I haven't found the person yet. I'm sure there might be somebody, but that we want to have quality of care, that's so deeply ingrained, that's a given, that should be the goal. So it is actually something that binds us all together if we're trying to work this out in different organizations. Still, although it binds, there are different incentives for different parties to get to quality. So for professionals, for example, it probably would be to provide the best care to the patient. But then if you look at commissioning and contracting parties, like the insurance company, for example, they probably also want the best care provided for the patient, but also for the best price. So another incentive comes in that they're aiming for, which is also, because often you see in public debate that insurance companies are kind of put away as the scapegoat and just the financial wolves. We want to all keep care affordable. So it might sometimes, because you feel the friction with health and economic incentives, but if we want to keep it affordable for everybody, then it is a thing that probably should be included, so that there are people guarding that. I will answer that question soon. That people are guarding that is a facet that is actually quite important in healthcare organizations. Okay, a question is, professional could also be doing it for the money. That is very, very true. I think that this goes for people in general, actually, that I'm being optimistic now, assuming that professionals' main goal is to provide quality care. But no, there are also definitely frictions there, because people are people, as we all are. In the Netherlands, oh, and it's getting less, but you used to have a system where providing some care, you would get a provisional based salary. So if you operate more, you get a bonus, which is a, a bit strange. Again, there's a friction with the economic and the health incentive there. So yes, professionals could also have that, but this is now maybe how it should be, I think. But okay, so is that if that did not answer your question sufficiently, then let me know. For now, I'll continue. All right. And then also for potential users, which is us. As I said, it's a given that the healthcare system should be based on quality incentives. So that's also something that we ask for, strive and want to, and actually expect from healthcare. So first of all, quality is an uncontested and binding principle. We all agree on that. But that's only one side of the coin often, because quality, as you already kind of, or I was hinting at already, is also something that can divide. I know from my own research, I did fieldwork in a hospital for 7 months, that if you ask the question, what is quality, that a nurse will give you a very different answer than a specialist or the management team. So what it actually concerns, how to get there, what do we mean by it, is not a static thing that we all agree on. So if you then, and that you often see in organizations, that because quality is such a deeply ingrained value that we all share, is that the conversation, what do we mean actually when we say quality, is often skipped. And then when people start organizing and working, they sometimes diverge from each other, because the goal in the end, how do we perceive this, is and can be different. So it is a dualistic concept that it does both these things. It binds us together, but it divides at the same time. One classical example of this is the professional and the manager. A professional, and I will go further here, you can see it, there's a little overview. There are some core concepts that that compose professionalism. So there's a deep expertise. I mean, most medical specialists, but whatever healthcare providers, specialized for a long time, have a lot of very deep knowledge about how the human body works, how to treat that, and would see quality as in the light of that expertise. Opposed from that, you have managerialism. As I said before, to organize care, it is a key component to maintain good organization and also finances then. But these two are almost two ends of the spectrum, because the incentives managers have can can be opposed to what a professional would say. Because, well, a very simple example would be, think of insurance companies that say, okay, you have this very rare disease and we're not gonna include that in our plan for this very small group of patients because it's too expensive and it will put the pressure up for the whole group, which then leaves this group out um, in the benefits of pushing costs for the rest of the group. And here you get an ethical dilemma, like if you're going to include everything, yeah, healthcare costs are going to go up. It's as simple as that. Do you want that? Are other people going to fall off then because they just can't afford healthcare anymore? Or are we going to include this group? And there you have two logics that in a complex environment like healthcare where things are not clear cut, that will always cause or can often cause debate and friction, and there's not a clear cut answer like that is the best way to go about it. But another one too, because that was a classic one between professionalism and managerialism, which you can study very micro in a hospital, for example, but also on a bigger scale with insurance companies, but also with all the different groups. You can see that what they find important in healthcare is different. Now here, if you look at this, this model, we have a couple of parties there. So the healthcare providers, patients, citizens, policymakers, insurance, public health actors, researchers. Now, if you look below there, Huber and all, they split up some core components of physical well-being and health. So your bodily function, spiritual dimension, quality of life. And these parties ranked what they find absolutely vital or how vital for providing health to a person and what health means. Now, what is, you can see the green line, those are patients, they find everything quite important. Well, that might be not a surprise, but and also in contrast to that, policymakers are, it's the purple line, they score quite lower. And then I always think it's interesting that the spiritual dimension, they don't consider that to be a core competence of well-being and health. This might also be a cultural thing, because I would say that if you would go outside of Europe, but this is, I must say, an assumption, I should maybe look for some research on that. We have a very rational based healthcare system, very Western rationality. So spirituality would not be something that would be held in high regard, as you see for most parties here, how they scored this dimension. It might be so that, let's say, you would go to Asia, that this would actually score higher. But that's, as I said, that is an assumption that I'm making. All right. All clear so far for everybody? All right, good. Okay, now quickly some history about how the healthcare environment changed, how we see quality, and that connected with how we organize it. This overview overlaps with the article of Grit and Dolsma that we talked about on Monday. But the things, what I'm discussing now is the article of Waring that looks over the last couple of decades what happens. But both of them, they are different studies, but do discuss this and waves of how we perceive health over the last decades. So as we talked about quickly already, so quality control and improvement as an exclusive professional issue, this was until when it shifted, as Grit and Dolsma said, from a more religious-based system, it then shifted to a professional system. So this meant that it was seen as a pure profession that should be conducted by professionals who are schooled and trained to do that. Pure professionalism, as you can call it. Then what happened after the 60s is that healthcare became a bit expensive and costs were rising and rising. So the question arose like, okay, how can we still keep this affordable? And what is actually happening in the organizing of health? Because a medical professional has a lot of expertise. But does he know logistics, how to organize it, how to effectively organize how these practices occur. So because the costs were rising, there was a shift to move it to the public domain, um, to actually see like what is happening. Still, by then, it remained the domain of the professionals. They remain to be the most prominent player. Now, I'm curious, who thinks this is a good thing to go by? Who says like it should be purely the professional being in charge of all organizational processes and practices? Just yes or no on the chat will do. No. All right, for the so why no? If you could. Oh, wait, I'm just quickly putting my chat a bit up there. Yeah. Yeah, it will rise costs. That's yeah. So everybody is saying no, probably not. That's I would agree, and I'm getting one here. I think it will rise costs. For example, sorry for the inconvenience with the PowerPoint. Well, I have to do it like this, I think. Just give me 1 minute. My computer does not agree with me at this moment. Well, maybe I'll give it a minute to cool down and then it will work again. Right, I'll keep talking for 2 minutes and then I'll see if it lets me access again. Yeah, I got some good pointers like, okay, no, I don't think so, and they're not trained for doing stuff like that. That is all very true. I mentioned before, like they have a lot of expertise, but on a specific and usually very deep knowledge level. Therefore, when it comes to organizing, keeping things efficient and costly, that might become tricky. But another thing is, and if my PowerPoint works again, that would be great. Another thing is that you also, when it comes to power division, all the power stays within the professional domain. So there's no control regarding what is actually going on. And when it comes to public safety and health, that might be a bit of a tricky thing to go by. As you can imagine, with all public services, usually there's, well, you have the classic division of health, the Holy Trinity, that is there to make sure that, well, people might not abuse, let's say, their power that they have, because if there's no control, there is a risk of something like that happening. Okay, I'm still stuck in my PowerPoint. And I'm figuring out how to fix this. All right, I think, why don't you all get a coffee? And I'm going to quickly restart my computer. Sorry for the inconvenience. I also don't know what All right, it's working again. That wasn't too bad, hopefully. Uh, okay. One second, I will share the screen again to go to my PowerPoints. Yes. If there were any questions or remarks that I've missed, they disappeared now on my chat. So if anything is unclear about what I was just talking about, then put it in again and I will address it. And if not, I will go on. So, as I just said, to have all the power at the professionals comes with a risk. Now, this exploded during the 90s and especially in the UK. There were a lot of fraudulent and criminal cases at that moment all happening and exploding, where there was a lot of misconduct. Now, in the article of Waring and all, you get an overview of what exactly happened, but I will just mention a couple from that because a lot of them were just organizational flaws, like latent inconsistencies in organization, which kind of had a chain reaction of healthcare protocol going wrong. But on the more extreme end, when we talk about no control, one very famous example was, first of all, the Harvard study that was done in 1991 that looked at 30,000 different hospitals and came mistakes that were made and came to the conclusion that 10% of health, well, failing is maybe not the word, but let's say failing, so causing deaths or doing harm to your health instead of making it better. 10% were due to errors made by either organizational processes or individuals. So that stirred the pot that government regulations came into about. A lot of research was started from what's actually going on. We should look more at the safety of our patients, also because a couple of researchers found that sometimes the professional incentives, so personal incentives, it might be money related, were often prioritized over patient safety, actually. The most extreme case of that is the case of Harold Shipman. That was a doctor conducting a lot of malpractice to actually kill patients. And he is still the biggest mass murderer of the UK, with, I think, something like 160 deaths hanging over his head, with deliberately killing his patients. So that stirred the pot to implement more rules and guidelines and have more government control. So that's what happened after that, is that we got the entrance of new public management. So that means that public services are divided over different parties that each control each other. So let that be the insurance company and the government, and then together with the healthcare professionals. And that would also be the system that we're still in at the moment. All right, so that were the different discourses and how it changed over time. At the moment, and I wonder how it's going to change now. I mean, you can only study this retrospectively because this year has been special, as we all know. But let's say this remains, is that the quality of care, like who is responsible for that or what should be the main focus, has shifted to the individual, so the patient. So if you look at how processes are organized now, the shared value of quality has been brought back to patient-centered care. So what is it that the patient wants? Now, this is This sounds pretty good, I would say. What it does do is that it shifts, it also comes with responsibility and with very complex care, and therefore more complex organizational processes. Because if you actually want to tailor make care for every person, that is well, quite a challenge. So coming back to the definition, like Huber et al. Have suggested one, and they also like bounced this off the original definition that we saw in one of the first slides um, from the World Healthcare Organization. And they suggest the ability to adapt and to self-manage. That's a very different way of conceptualizing health, let's say. And it's very individualistic as well, which also comes with responsibility for the patient, maybe. All right, measuring quantitative frameworks. So with all these developments, you see that a lot more regulation and safety has been implemented, but also a lot more research. So, like, how can we check up on this, and how can we ensure that this all goes well, and how is it actually going? Now, the usual starting point, and which has been developing the last 10 years, are quantitative frameworks. Now, one example, I think this exists for like about 10 years now, maybe a bit less, for the non-Dutchies. This is the healthcare map of the Netherlands. And it is designed that you, as a patient, because we want person-centered care now, you can grade and put your personal opinion about healthcare organizations online, and it provides a ranking. So for advice, which hospital to go to, which physician, whatever care you need, you can look up which grade people got. So these are two examples of interviews that one of my colleagues held, looking at how to measure quality of care. And when she talked to medical specialists, these were two remarks that she mentioned, that were mentioned. So one of them, there are no good hospitals, there are good doctors. I would say that's, I think it's an interesting remark, because one of the problems you could think, or perceived problems with Zorgkaart Nederland, is that you can actually review people by name, and their name is out there. So when it comes to the protection of the identity of a doctor and things that are written down there, there are some downsides to how that is working. I mean, imagine if everything you would do could be graded online and would be out there for everybody to see. Nevertheless, I think this is a defense of a medical specialist. Nevertheless, this goes back to the professional discourse, as we talked before, that healthcare should only evolve around the individual medical caregiver. So cuts out organization as a whole. The following quote from that is meals all right, enough space for the family. That has nothing to do with the quality of care, logistics in order. It's not about that. Quality is about a team that treats a patient with passion and respect. Now, although I think the last sentence is hard to disagree with, and hopefully caregivers give care with passion and respect. Is it true that all these things that are mentioned before do not matter? Is what kind of food you get, and if your family can visit, and logistics, by the way, I think are quite important. If the logistics are not in order in a hospital, I think all problems could potentially occur. So is it just the healthcare provided by the caregiver, or is it also the organizational aspect and how you're treated as a patient? Oh, yeah, I looked at, so I went into the Zorgkaart, which I always think is quite interesting of what kind of reviews people get. So also, what I kind of want to discuss here is that these are rankings that give you a certain type of information. So if you are looking for a healthcare giver or a healthcare facility, they can definitely give you extra information of where you might want to go or what is important for you. But there's a tricky thing in that you first see the grades um, of the hospital or the caregiver. And as with anything, actually, I think, well, we live in an age where we can look up all reviews on everything. The quality and not the quantity, so not the grade, but the quality of the review is quite important to take into account. So the first one, for example, maybe take a minute to read it all. Yeah, so I think if you look critically at this review, um, I get more questions than clarity from it. Like, for example, they deliberately ignored my request to speak to a doctor. I'm just wondering what actually happened here. So it's quite normative and colored, and we all have the freedom to write these reviews. That's fine, but if you look it up yourself, see what information it gives you, but maybe more importantly, what information doesn't it give you? Because there could be a whole lot of different scenarios that were going on here. So what does this tell you really? What is the quality of the review? Second one here, neurologist XXX. I changed the name because that's the thing you can put in the name of the neurologist, which I feel friction with that it's so personal, but okay. Let me wait for 45 minutes and he talked to me in an extremely unpleasant way. Arrogant he was. Well, here kind of the same thing goes. I think there's not enough detail to actually know what happened now and how this neurologist was treating the patient. So that would be my 2 cents. It is useful, but also see the information that it lacks if you want to use these frameworks. All right, I think for now it's almost a quarter to 11, and I'm gonna try to be timely if the technique works with me today. So let's take a 15-minute break and be back at 11 and do the second half of the lecture. All right. See you soon. Hello, welcome back again. All right. I hope most of you are back again, maybe 1 minute, and then we'll start off. Mhm. Mhm. All right, here we go again. Yeah, this is where we left. We were talking about the zorgkaart. Wait, let me get the chats. Now I am, and this is out of curiosity myself, like what I know from the last 2 years of giving this course is that usually the medical students have a very strong opinion about the zorgkaart. So I don't know if any of you who might be studying medicine at the moment have remarks to make about this way of measuring quality of care. Can also be in the chat. Well, I see somebody typing, so let's see. But maybe not. Well, usually they're quite outspoken and discuss the well, the privacy matter and maybe being bashed a bit as being a healthcare professional and how contextual providing care is. So that is often mentioned, which I always find interesting discussions that would be easier to do if we would be physically together. But right, for now, let's, oh,
I'm not a medical student, but I think the privacy issue is quite like something important. Um, and see, and you can see also like with the new law that the AVG, it's something like you need to think about it. So yeah.
yeah. Yeah, but that's like I often think like maybe they it would be good to anonymize it, but that it would be like a tricky question because let's say you go to a GP practice where there's one GP or two, I mean, then it's a bit of an illusion of privacy anyway. So, I mean, there is a trade-off in that because there are benefits for having these measurements, and it does provide a bit of, well, you get feedback as a healthcare professional, and there's a bit of control to keep quality up to standards, but there is a trade-off with that one. Yeah.
And I also think that a lot of those things that are mentioned are out of the control of the physician, because I'm studying medicine and I know there's a lot of administrative load. And for example, the one that said that neurologist let me wait for 45 minutes. That can also be because there's an emergency on the other side of the hospital. So I think it's a little bit biased.
Yeah. Well, that is the thing. It is subjective in that sense. So that's why I wanted to empathize, like, be critical when you see this information, like, and that's not to serve it off. Like, there's nothing in there that can be helpful, but be critical of what you are actually reading and what information it gives you. Also, in my experience, well, it's not totally true, but I always expect to wait for half an hour at my GP, but I just, because that was always the case, because things can go different. And you also have the system that is also so by the pressure of the insurance that every appointment is 10 minutes. I mean, that's not that's not a lot of time if you look at how complex health issues can be. So how can you provide person-centered care if you have it regulated in time frames? So that is a friction point as well in that sense. I must say I switched my GP though, and I every time it was on time now, so maybe I got lucky. But okay, yeah. So that's one way of measuring, but we also have some others, and that's you have a lot of hospital rankings, for example, because in the Netherlands, and this is different in some countries, but the principle of that you can choose where to get your healthcare is regarded quite highly. So we get to pick if you have the right insurer that has a contract with most of the hospitals or whatever care provider, and you have these rankings. Now, what is it that it can bring us? What does it help us with? And that's, first of all, as we talked about before, the shift of the discourse, bringing it to consumers' choice and the customer. That is a benefit of this system. It also can make quality transparent. Again, what is quality, as was just addressed, is a tricky matter because some things are out of the hands of the medical specialist. But it is, you get feedback. I was also mentioned in one of the comments on the chat, like it's good to get feedback, but so it is, it can be very constructive and valuable to actually have a bit of pressure on keeping these processes in check and on standard. However, when it comes to these hospital rankings, you have multiple and they all diverge from each other. So there you already see the flaw in maybe the way it is measured, which hospitals were included, like how watertight it is, because some hospitals do well in one and not in the other. So what is going on there, you might wonder. Also, a lot of lists exclude academic hospitals, but some do not. Academic hospitals always score low on lists, which you would think that's strange. Just for the people who might not be aware of it, in the Netherlands, hospitals are ranked in three different divisions. First one, academic hospitals, then you have top clinical, which is not an education provider, but does provide more complex care and specializations. And some education there, and then you have the general hospitals. Now, what the thing is here, there is an explanation for it. In academic hospitals, there's more complex care because they are the only provider for that. You usually don't have that in general hospitals. Now, when the care gets more complex, the goal of sending somebody out totally healthy and fine might be a bit more tricky to achieve, if even possible. So that's why these hospitals rank lower. So here you see like what's behind and these rankings and how they actually got there is important to keep in mind and look at. It just gives you a specific set of information, but it's not a general overall knowledge of what is actually happening there. So again, also for this one, be critical and think yourself, what can I get out of this? And what is information that it does not provide me with? So why do we use quantified quality frameworks? It's to generate objective data that allows comparison. Well, already discussed, this is a bit of a tricky matter because quality is a contested and ambiguous concept. So how do you measure objectively a subjective concept? That is a trade-off, and maybe the question is whether that is feasible to fully do. Break the professional dominance by challenging their assumptions for their own exclusive knowledge. This is what we talked about before, a division of power, and also put it with the patient. There is, to get the power away from the professionals to avoid that they have total power and domination in that, and to avoid malpractices. This is a good system to check upon that. Demystify the professional practice. So it's also, besides shifting power dimensions, it's also aiming to make it more transparent, where before the knowledge of the professional was something almost inaccessible for anybody else who did not have that knowledge. It's opening that up now a bit. So it makes management possible and shifting the power balance away from professionals. But there are also some critiques to quantifying quality of care. It is selective. So it is not whether I had great care or experienced my care as bad or good, whether I'm going to put it online, that's another question. So you get a selective group who you actually are, or who we are basing those grades on that you see on the Zorgkaart Nederland. While there might be like a lot of people out there who had great experience with care or very good feedback, I never wrote a review in my life. Well, for an article I did, but online for a service I got, I never did that. So you're excluding that group. So see the lag in how much you can generalize that data. So they give an average performing, concealing the diversity within that. And that's not how to generalize it, but within an organization and what happens there. Like it's also, I was looking at the Zorgkaart now, and then you have people that suddenly give one thing that happens a 1, for example, which pulls the grade down of the practice. And it was also a lot of them, there was with one GP practice, said like, oh, this is actually a great GP, but his staff at the front line, let's say, at the desk, they're rude and horrible. So that's why it ranked very low. So also in that, it's not 100% complete information. Some more fundamental critiques. It's the assumption of a linear cause and effect. As we talked about before, it assumes outcome. So it looks at the end stage in that. It does not include the complexity of different things that already happened before maybe somebody got pissed off and wrote something down. So the process is not included in quantifying care provision. It's selective, so what is and what is not. As we said before, whether the things that are mentioned are the task of the practitioner, or maybe it's a matter of the insurance company having some protocols that you do not see. So it's just little snippets of what somebody wanted to present to you. And the different perspectives. So, and that those two go together. It is selective because we have different perspectives of how we see health. Okay, when is it appropriate to measure or not? I'm going to post that question with you. Maybe think about it a minute and speak up or put it in the chat. Oh, and a question here, if the Zorgkaart is an example of quantified quality framework, because it's not objective data, right? That's exactly right. Although it is in the end quantified as a grade, because that's the whole system to grade it by number, your healthcare provider, but it is based on subjective experiences. So I'm going to skip forward now. I think this is very important to keep in mind. Measurement, definitely, when it comes to quality, has benefits. But because of the peculiarity of what kind of care you need and how personalized it is, and how the organization is arranged around that, it is something that is hard to generalize. It depends on the type of care practices that you concern. There are practices, well, let's say operations, that are more standardized than others, of course. This is the difference between complex care and also the more protocol types of care. So there is a distinction in that. What is the service that you're provided with? And also, people are different. So we're not robots that all have the same parts and work in the same way. So it's in the end, it's humans that we're talking about. So there's a limit to how generalizable that is and standardized it can be. That's also why we need medical specialists with the deep knowledge and expertise that they have and the practical know-how. This is also the paper we talked about, the review on Gadamer in the first lecture about rationalization of care opposed from the art of healing and the medical know-how that medical practitioners have. They stand opposed from each other. They are inherently intertwined. Because of course, rationalization and scientific measurements can improve health. And where would we be if that didn't happen over the last 100 years or more? But they're not absolute. So 2 key assumptions. Identified and measured. I think that we talked about that. So this is a very rational view, like this is a problem and we need an outcome. So we get this tool and work with it. Those are the technical aspects. And there's a normative assumption, but that also depends on the care practice, is that we often skip to even question what good quality of care means. So it's so deeply ingrained, that's what we need to do, that that conversation is often skipped, while there are a lot of diverging perspectives on that. Now, one example, I think, of where protocols and the human side of providing care are often contested with each other. That would be, it's one example, but life at a nursing home. And then, for example, I think it was last year, especially I think in nursing homes, you do find people with dementia and Alzheimer. And last year, a nursing home got fined because, and it was in the news, everything. There was this woman who always put bleach in her toilet because she liked the smell and had the feeling that it was clean then in her house. So they let her do that, but it goes against safety protocols. So they got fined for it. And there are numerous examples that you can name when it's comes to these friction points, like do you lock doors when people walk at night? Do you lock them up? Because safety protocol, yes, you do. There's friction, though, that you cannot rob somebody unless you are a felon of their freedom. So do you go for safety or do you go for autonomy? And these are really the often very cringing breaking points where, and also for actually the caregivers who are working in that context, because they can also be held accountable for this, like where the human and the rational side can really clash, and that's where it can become very tricky. All right. All right, one more example here. This is a shared decision-making survey that is used all in the Netherlands. A colleague of mine conducted this research as well. So I got it from her to see if, because we need patient-centered care again, if actually patient and doctor are consulting. So this survey was handed to patients who just had an appointment with the doctor. Now, I'll give you a minute to skim over it quickly, and maybe then let's reflect on it. Like what, I mean, we've talked a bit now of what kind of information you can draw out of these quantified frameworks and whatnot. So take a minute and maybe then reflect on it a bit. And as always, you can also always put questions or remarks about this in the chat. Yeah, one remark here. This survey only looks into what the doctor told and not what the patient thinks about it. I think that's very good remark, because I remember seeing this for the first time and I almost had the feeling of some kind of protection for the doctor. Like, okay, as long as we check the list, that he followed or she followed the protocol, then it's all good. Any other comments? It's more about what they've talked about, not so much. Yeah, so one comment here, it's about what they talked about, not so much if there was any decision to be made. Yeah, and this is also the, I think, a key pointer with these standardized question lists. It totally excludes what the problem was. And as we just said, I mean, whether somebody has an infected toe or more complex care, that if you have a horrible disease, whatever it may be, that's very different. Oh, sorry. Okay. I also think the use of the word exactly and precisely might make it more difficult for the patient to answer, and I'm not clear on how this connects to the nurse. Is that what you mentioned earlier? I'm not sure about the nurse. Maybe you can clarify that question. But yes, well, that's also, again, these are quite subjective. Exactly, precisely, what do you mean by that? Another comment I thought, though, if they would be asking what the patient think of it, I would have a problem again of quality being differently interpreted by different patients. Yes. All right. I think, thank you for all the remarks. But here you see how it gives you a specific set of information and definitely not everything. So what does this tell you now? And again, reflect on that. Like the first one, my doctor made clear that a decision needs to be made. Is that, for me, I thought like, okay, the last times I went to the GP, that question wouldn't even have been relevant. So it also has the assumptions that you need to kind of have a yes or no or straight plan after that. But is that always the case? So how the experience and interaction went between the two, you do not see that here. Now the thing is, the Zorgkaart Nederland, for example, people do write down their experiences with healthcare. There, however, you see that a problem is that it's really subjective and every patient needs different care and has a different perception of what is good care. So these are all examples and ways to give you information about this, but you cannot see them as purely rational, objective information. Not this survey, very quantitative framework, and also not the experiences that you see on Zorgkaart Nederland. All right. So that was quantitative frameworks that are used now, a couple of examples of them.
I had a question, if
Yes.
it's possible. Well, it was asked what should be measured and what is actually being measured, but is it now true that it's not really, we're not really able, sorry, able to say what should be measured because quality is pretty subjective for everyone? Okay.
I think that is a very fair remark. That, well, to pose it in an extreme, and then we go to the philosophical foundation, I think, of quality of care. Like, is it even possible to have a rationalized, objective definition of that, which maybe can be split up by different dimensions, and then arrange care around that? And even if that would be possible, I think that's a subject, and I always think this is not so satisfying maybe for you students that I'm going to say I don't have a clear-cut answer, but I actually, for good reasons, I hope, am doubtful whether that is even possible. And you can debate it for years and years, as researchers and public policymakers have been doing, because even if you reach a state of, okay, we're going to look at this, which is good, because you need, if you have nothing, you have nothing to organize by. So that there is discussion and debate, and things developed written on paper, that does provide a framework to organize care, but to see the lack in it, that it's not an absolute truth, I think is very important for reflection. And also because, as we have talked about Monday, but also in this session, our perception changes over time. We see healthcare very differently now than we did 100 years ago, even 10 years ago. Also, what is going to happen, what is happening this year, it's going to change our perception as well. So it should always be up for debate and up for discussion and be developed further, but do not see it as a total objective, static, rational truth, I would say, that will always stick until the end of time. Does that clarify that for you?
Yes, it did. Thank you.
No worries. Thanks for the question. Okay, so the article of Waring and others, well, we already talked about the little historical outline that they provided, but after that, they go into that you have different ways of approaching quality. Now, the first they discuss, which is the one that we have just discussed, is the mainstream one. So that is based on quantitative frameworks. So how can we measure and how can we get a grasp of these quality measurements and organizational practices? As I already said, it's not about that. This is not a, well, now I said versus, but I would, and I think they do as well, but I should actually say and between these two. It's not about one being better than the other. It is, though, that with every approach or perspective that you would have, it is never 100% complete. So often, and that's also the argument that they make, these approaches should not be seen as exclusive, but should actually be complementary to each other. So yes, there are a lot of virtues in obtaining quantitative data about healthcare. But what it does not answer is actually the more human sociological side of arranging care. So they make the plea to maybe go for both more, because we are very based on a rational framework and that misses certain information. Like one example that they give and why they plea for a more sociological approach is that organizational processes, they're all relational and entangled with each other. Sometimes you can get a chain reaction of one unintended consequence that gets out of hand to um, practices that can actually pose risk. Often these are very ingrained in cultural rules, norms, and values that you have within the organization. A hospital, for example, has so many different subcultures and usually quite traditional hierarchical standards, let's say, that the social process does influence how care is practiced. So, well, shortly to sum up, so the mainstream approach looks at systematic measuring. Whereas the risk, can we intervene? It looks at it as a static thing and more on the structure side of how to organize. So also the culture structure thing and the friction between the two could also be put on the mainstream as being structural, and the cultural side being more sociological. Yeah, so, okay. So the more technical mainstream approaches, they have some critique on that, and that's that it can be too linear. So we think of it as just the domino effect. Like if we do step one, we get to step two, we get to step three. Well, often, well, even if you with the example at the doctor's office, your GP's office, that if you have an emergency happening in between these processes, the original linear plan of having 10-minute sessions the whole day already doesn't count. Also, still, it's human. You're working with humans and it's human work, so it's not so clear cut. It's usually not a step-by-step plan. So they continue their argument saying that this type of thinking is too superficial for actually managing healthcare. There should be added something to it, like culture management, what is happening with how people organize and how it is organized. For this lecture, the question then of how do we actually perceive quality and how they can diverge would be a question to be posed. So they come with the alternative of the sociological approach, so that the care practices are embedded in broader social, cultural, et cetera, structures and processes. All right. Yeah. I'm sorry. I'm missing one thing from Campbell. The article of Campbell, and I want to put that one next to the article of Waring. Campbell and others, they do provide a definition of care, and they actually do that quite extensively with dividing different dimensions that are all or should be taken in account for quality and providing quality of care. If you look at that article though, and framework they provide, that would be, according to Waring et al., a mainstream approach to it. Like they talk about that there are two dimensions. So you need access, which is interesting. I thought that one of the first, they said the first dimension of quality is that you have access to healthcare. Then I think that is, wouldn't that be more of a given than a separate dimension? But okay. And it should be effective. Now, again, if you had an extremely unpleasant experience with a caregiver, is that then quality of care? Because it could have been effective. Maybe, and also think of pain, for example, that is not included in that. So it was effective, but it was very painful. So it's quite static in that. And although they do mention that it's also about interpersonal care, for example, they kind of put that as a side element and as a tool. So their article would be more mainstream. However, they do provide a very good basic analysis of elements that should be included. So it's not the point to make that this study is not good to address quality. It just focuses on specific elements and leaves out others as well. So, okay, well, you've seen this. Now, on a more micro level, the article of Pulse makes this very apparent with looking at a very simple and basic thing, and that is washing. So she did research in elderly care homes and also mental and psychiatric care homes, and looked at what good washing actually is. And this came forward from the question how to account for such. So how can we standardize the very simple, you would say, practice of washing a patient? And what she got to, because if you want to standardize that, you should think of protocols on how to do that. So this was a very longitudinal study of a couple of years where she asked caregivers, so what do you think of? What does it mean to do good washing? So she found that there were different ways in how the caregivers perceived that. So the first one was routinized washing, and that was very simple. What does it mean to wash? People need to be clean. It doesn't matter how or what, they should just be clean. And we can account for that because there's a step plan on how to do that. You start with the feet and end at the top. I'm not sure. You can routinize that pretty easily, I would say. So routinized washing. But then there were other caregivers that said like, no, but there is always this part of the autonomy of the patient, because you can imagine if it's a basic principle and regulations, you need to wash somebody. What does the person do themselves? Like there's a difference. Some people have more trouble with doing that themselves than others. And to also mentally and keep people healthy, let's say, to have them do their own activities is a big part of actually providing care. So the second way you could account for washing or see the quality of washing, how you should do that, is that you also learn people how to do it themselves. All right, third one, people's autonomy. Some people do just not want to get washed, or maybe they want to be washed in a different way. I mean, I'm sure we all have different routines when we get up and how we get clean. So, should it be based on what the caregiver says and accounts for and says, okay, this is what we're going to do and this is how I'm going to wash you? Or should it actually be a consultation with the patient, like, what do you want? Do you even want to be washed every day? Do you want to have your hair washed every day or not? What do you want? So now the argument that she makes is that it is not a matter that one of these three is the best. They all have their pros and cons that you could argue for or debate against whether you should do that. But what she proposes is that it should move towards contextualized washing. So all these three perspectives should be included. And from most of the caregivers, they already gave her the feedback like, okay, it depends on the person. I know these people that I'm working with for years, and you see what works the best. Now, what you get with that is that you get attention. Well, first of all, between the clean and autonomous. So, is it something, if you account for it, that is so regulated as a universal principle in the Netherlands and standardized in that sense? Or do you have an individual consultation, let's say, or way of washing with every patient? Yeah, same point. Each principle can be criticized from the other. And she makes the argument in the end, like what, well, vows against the fixed quality measures. And I think what is, I would suggest for you to read this article because it's such a parsimonious and interesting way how she makes this point, so with using such a simple activity as washing, that the flaws or the lack of these fixed quality measures is hard to implement actually in practice. So therefore the vow for make it contextualize and do not standardize everything, because it is about care, which is inherently a personal matter. So, and also brings it back to quality. Then with the example of washing, it means different things depending on which perspective you take. All right, some conclusions of the day, although I think we talked about it quite extensively. So from the 1960s and onwards, efforts to external control over the quality of professional care. This was how we started with the article of Waring, like how the discourse changed on this over the years. Because of the division of power, bringing it more back to also the public instead of only the professionals, more quantitative measurement frameworks were implemented also to make sure that procedures are safe. So this is also, we have been critical about quantitative measures now, measurements now, but as a safety and protocol percussion, there are also some things that is essential with organizing such. So quantitative measurement frameworks does help to make sure that power is divided and provide risks to the patient, but when is it appropriate, what not, and what are the boundaries of measuring health in this way? So both go together. So we talked about the different struggles on quality, how to manage such quite extensively, I would say. Now, here we go. So the most general way to approach this is the mainstream approach, break it up, measure. It allows for external management, but the critical side note, when does it apply? When does it work? Nope. So last remark, and then I think we're 2 minutes before. All good. Yeah, I'm gonna put both. Sorry, there was a question if the paper is going to be available on Canvas. The one from Monday and from today as a PDF, I will put on Canvas today. So I think you now hope you got a bit of an overview of the different developments in care concerning quality and the different measurements and approaches that we use and how they all have something to add and something that they lack. Definition of care, we've seen a couple. The one from Hippocrates might be the one that would be most, well, it's not exclusive little boundaries, but cuts to the core of doing health. And that's the principle of first, do no harm. And then it depends on the zeitgeist we're in, how to arrange that. So that was my final remark for this session. Now I have some slides, just little pointers concerning the essay assignment, 2 slides, I think. Let's take a 15-minute break. I'll quickly gonna go through those then and also address some of the questions that occurred multiple times through the emails that you sent me. And then I'm gonna put you in breakout rooms and we have another 45 minutes and that will be the day, but I'll see you in 15 minutes. Yeah, all right. See you soon. Hello. Welcome back. Ooh. All right, it's 12, so let's start off. I put down some of the main pointers that are also based on other years and the questions that I get from students and what they sometimes have trouble with, also because you all do different studies. We have a super diverse group. So what I heard a lot the years before is that sometimes how to plow through these quite extensive articles that are mandatory, that can be a bit difficult at first if you're not used to it, especially if you look at more the beta studies and more quantitative research articles are usually very differently structured, also shorter often. So it can be definitely getting used to looking at qualitative data and articles that come from a social science tradition. So if you get lost a bit and think, ooh, what is this about now? Just some very simple pointers like skim the abstract and the introduction. They will tell you the main points that are in there before you proceed. But also, if you're looking for what the core arguments of the article are, look at statements and signal words. Like in this article, we contribute in these 3 ways. If you skim through it and go look for that, that could give you some grip to get a sufficient understanding of the point that they're trying to make. And of course, hopefully they will be helpful to you, that the lecture slides that me and Jannes use can also help you out for some clarification there. You can test that with trying to see if you can produce it in your own words or look at examples, especially because you have to do an essay assignment. Like, try to think of like, okay, what is the argument that I want to make and what do I need to back my argument up? So you can test yourself in that way. Then some tips, I think. Because it's an essay assignment, and I did get that question over email a couple of times, you are not writing a report. That is something different. What is essential when it comes to an essay is that you do have a position as a reader. Now, this does not per se mean that you need to say I'm against or for this, or be very extreme in your positioning. You may, if you want to, but it can be more nuanced and complex in that. So, as I said before, the standard or the classical essay format usually concerns a thesis antithesis build up. So that would say like, okay, I have a statement and for or against. That is one way of going about it. What you could also do is state a topic of interest, go explore it, see that there are multiple views, because often, especially as we have just discussed with the complexity of healthcare, often it is not a yes or no matter. And there are more views that are not black and white that could apply to the question that you have. So if you build that up, or when you have a statement or a topic of interest, if you discuss the different views, you can use that framework to work towards like, okay, now that I've taken the complexity into account, I think that this is where we should be heading if you want recommendations, or maybe you want to make the point, let's say that quality is an inaccessible concept to have a black and white answer to. So you can play around with that, with how you want to do that. But that you position yourself is an essential part in that. So another thing was that I got a lot of, I think all the topics actually that were emailed to me were very feasible and good. I haven't seen one strange one that wasn't interesting and possible. But it is so, the course is healthcare management, so that you integrate that perspective within the literature and the topics that we talk about, so that you make a link or embed it in. So how is it organized? How should it be organized? That is an essential part of finalizing your essay and discourse. Okay, be reflexive about your conclusions. That is just the principle of, although in an essay you are allowed to have your, wait, I will answer that question shortly. You are allowed to have your own stance and position, but you cannot do that without backing up that with content, knowledge, and research. So to make it transparent and have an argument that builds up from academic data, that is a core component in that. You cannot state something without backing it up, basically. Making decisions about what's important or off topic. We only have a couple of weeks. That's the peculiar thing with this course. We are a bit in a rush. It is quite high pressure also for you guys, I assume, but luckily you don't have any other courses and you will get 6 points for it. So we can expect something. But there's a lot. I mean, you have big topics of COVID-19 and organizational science. Make sure that you do not need to talk about everything and include it, but only select on what is essential for your topic. You will probably find it troubling if you want to do it all. So also what I said to a couple of you responding to your emails is like, make sure to keep it parsimonious for yourself. Don't go overboard. Sometimes a very small matter can be very complex and worked out in an essay. Like there was one question, I think, to do a comparison of different countries. And the author of the email also stated herself that it was a bit too broad. Like that, I would think for the 3 weeks that you have, I think by now, 1 day longer, would be complicating it for yourself. However, I want to state you all have different backgrounds and disciplines and experience with essay writing. So it is a matter of what works for you. So if you think like, no, it's totally fine that I'm going to do a comparison of different countries and make it complex, then you should definitely do it. It's just a warning at the start, like be careful with that, because it's a short course that you don't bite off more than you can chew. But I am very sure that you are all capable of knowing what works best for you and what's feasible within your own experience and capacities of what to do. So last point blends into that, fragmentation or integration. Integration is key here. Don't go overboard with too many topics. Try to have a focus to make it easier for yourself and also to just compose a clear, nice line of argumentation. All right, questions 2. Do you need to use one article or more? I need to check that with Jannes, because former years we said that it needs to be 3 articles. But I know he has changed some things about the assignment, so I'm going to check that, and I'm going to put that on Canvas, what the exact number will be for that. Okay, is there any moment to get global feedback or not at all? Well, I mean, articles from the lectures. Ooh, you mean if you have questions about the articles? In these sessions, and what I could do, like, you're not going to get feedback on the overall essay because of the time constriction and because we have 2 lecturers. So that would be difficult, but that's why I did open up the extra line this week for feedback on your topic. Questions about the articles can be posed in the last session of the lectures that we have. What I want to do, what would be good maybe, is that if you have a specific question about the literature, sorry, I got distracted by a question. I will answer that. If you have questions, you can send me an email. And then what I'm going to do is I'm going to either respond to you personally if it's a very specific question that might not be of relevance for the whole group, or I'm going to discuss it, make a list of the questions that came and incorporate it in the next session. So if you have questions concerning the first 3, is there a rubric? A rubric is on Canvas for the essay. You can find it in files. Dana, you missed the announcement on feedback on your topic. You can still send it to me and I will give you feedback before the weekends. Yeah. Are that all? Yeah, okay. Just a couple more questions. I thought it was a bit too early, that announcement. I wanted to have some more background on what the course was about before I had a good idea about the topic. Yeah, I understand this remark, and I also got an email about that. First of all, I want to say that that I said that you could send me the topic was in the fluke of the moment as an extra service to provide for you. Originally, that wasn't meant to be, but I know that it's a very high pressure course. The reason why I said do that the first week is because we have such a short amount of time. If you're only going to think about your topic the second week, you might get in trouble because writing is a process of rewriting and chewing and reading. You're going to be time restricted in the end. So I know that's not ideal, but that's just the difference between an 8-week course where you have the time to do that, and this now being a 4-week course. However, as I said earlier, like for the ones of you who want to send me still their topic, I will respond to that because it's 2021. So let's, I'm not going to be difficult about that. The use of 10 academic articles, that is correct. There are 10. I just want to check with Jannes before I say something not consistent, how many should be of the mandatory literature and how many you can select yourself. So that's a question I will come back to. All right, are there any other questions?
I have a language question.
Yes.
Because I want to write my article a bit like about communication between healthcare institutes and the public or politicians or anything, or like maybe make a more like a discourse analysis.
Yeah.
And since I'm not Dutch, can I use also like English sources, or maybe also because I'm German, use German sources, or like also
Yes.
analyze German language? Of course, I will write it in English, but just that I use other languages than English for my research.
No, that's totally, that's absolutely fine. You can draw from whatever language that you can. Just as long as the essay is in sufficient English, then there's no problem.
Okay, yeah, thanks.
Any other questions? All right, then I'm gonna put you in breakout groups now. And what I would like you to do, or what I would suggest, maybe you want to do something else that is better for you, that's fine, is discuss the topics that you have selected with each other, and also think about what literature or what maybe sub-questions would be interesting for proceeding with your essay. All right, now I'm gonna see breakout rooms, and I'm gonna drop in, and I think I will move how many people. Oh, we're only with 27. But that's the core group, I think. Let's see how many we will do then. So, well, maybe people come back now, 30. I'll make it 5, because then there's also more time for me to check in with you. All right, so I'm gonna put you in the groups, and see you soon. Is this working?